questions as they come in, and we will stop at the end of the presentation and review the questions and answers. We also can then have a record of all the questions that we can print out rather than using the phone. So with that, we are scheduled until 2:30. So unless anybody else from the team in the room has something, we will go ahead and proceed. So if John, you go to the next slide. All right. Here's our implementation schedule that if you've attended a number of the trainings that we've done over the past few months, you've seen this slide. All we did was make a little update to the OTP, the yellow highlighted one that you see there. We will definitely make the slides available, and we do intend to make the recording available. The actual manual at this point is available at bh.medicaid.ohio.gov in the manual section, so if you'd like to go and download that, you may at this point. We do have a little caveat in here that we will talk about in a little bit later in the webinar. While all policy coverage is going into effect January 1, 2017, some of the technical is a couple of few days later than that due to configuring MITs, but it's pretty close enough that we don't believe any bills should really make it quite into the system yet or not. So we'll talk about that in a little bit, but we wanted to keep everybody aware of the implementation schedule. We will cover only the OTP changes today. We will not cover any of the other changes that will go into effect July 1st, but we wanted to do this. Just as another caveat, we actually have a pretty diverse membership on the line with us today, consisting of existing OTP providers, being the methadone programs. We have a number of the OTPs that are SAMHSA, Substance Abuse and Mental Health Services Administration certified, that have registered. I think we have 7 of those. That's how many when I looked this morning. Some of that cuts across both. We also have a number of boards, a number of other interested providers that are listening in. And we very specifically invited managed care plans because particularly on the MyCare Ohio side, they will need to do technical configurations to support this level of change that we're putting in place for January 1st. So we probably will get a myriad of different questions as we're working through this. And again, as I said, at the end where we have the question slide, we will go through and answer those. Usually we don't answer all of them. So when people were saying audio isn't good, we can't hear you, of course we don't really those, but we will address all the other questions that we can. So if you go ahead. Here's our agenda. I don't really need to go over it, but we'll go over these different sections about the manual, billing guidance for the different OTP types and some of the other coding, and then we wind up at the end with national drug coding, NDC, because all medications need to come in with a national drug code, which we use to identify the manufacturer, the product, and I believe it even goes down to the dosage amount. So if you could go to the next one. As I just said, if you go to bh.medicaid.ohio.gov in the manual section, you will actually find what we call the final version 1.0 of the OTP manual. Again, I mentioned earlier that what we are focusing on are actually the OTP changes. It is not the whole behavioral health redesign for July 1st, but rather just the things that are going into effect January 1. There's a little bit in the manual we have to address because of a code that is shared between general SUD providers and the OTPs, but by use of a modifier, we have a way that we can price and pay accordingly depending on the medication that you're providing to the individual. Next one. All right, let's do a little overview here. As part of our redesign, we have come up with a way to add coverage for our existing OTPs, the methadone license programs, a select set of additional codes that represent activities and represent medications by J codes, and we've also bringing online for the Substance Abuse Mental Health Services Administration, SAMHSA certified OTPs, a way to provide daily dosing and take-home administration of buprenorphine-based products. But just as a level setting here, if you go to Ohio Administrative Code 5160-30-02, that is the coverage and limitations, I believe, rule for SUD treatment programs under Medicaid. It's a very specific rule that authorizes the coverage that we're bringing up here of physician-administered pharmaceuticals. That's the term that's used in a lot of Medicaid rules, so put that here. The appendix of that rule is a payment rate table. So you can go and pull that appendix, and it has all the different codes and the rates that are there. Just want to remind everybody that even though we have a very specific rule noted here, all SUD services provided by Department of Mental Health and Addiction Services certified SUD treatment programs are governed by the full 516030 chapter. So there's, I think there's 4 in there, 4 or 5 rules at this point. But also want to remind everyone that there are general Medicaid rules found in Chapter 5160-01 that also govern this part of the Medicaid program here too. But very specifically around this, you can go to this rule and you can find the coverage and you can find the appendix that has the rate tables. So our second note here on this screen is that we will use the HCPC code H0020 as the only code that's available for a face-to-face patient encounter when methadone is administered on site and for take-home use. Now, in order to do pricing, we need modifiers every time that this code is billed, and I'll talk about that in a little bit. And in this instance, that code, the H0020, covers payment for the administration and the medication itself. So there's no additional billing on top of that for the medication, which I'll talk about in number 3 for the buprenorphine products. But this one is actually very similar to what the OTPs use today. They're going to get paid the same. The major difference here is that we will need you to append a modifier so that we know the dosage that has been administered to the patient. So number 3, it's very similar, but it has a couple of uniquenesses because of the medication itself, but we're bringing online a new code, T1502, which will be used to bill for the face-to-face patient encounter when a buprenorphine-based medication is administered on site and for take-home use. Again, you'll have to use an appropriate modifier, and actually the modifier schema we use is actually exactly the same independent of the 2 codes, and we'll talk about that in a little bit. But in this case, the T1502 covers the administration of the medication, and then you actually have to bill the medications in addition to that because these are a more expensive medication than the methadone itself. So that leads us to bullet point number 4. So just for the buprenorphine-based medications, you will need to bill a J code, either J0571, J0572, J0573, J0574, or J0575, depending on the milligrams of the medication that the patient is given, for the office-administered buprenorphine-based medication. Now, this is a little different because for take-home administered doses of the buprenorphine-based medication, you have to switch the billing code to an S code. You can use S5000 for generic, and that is a per milligram code, and we'll kind of keep repeating some of this as we go. And S5001 is available for brand name medications, and again, it is a per milligram code. And I mentioned earlier, but all J or S code claims must come in with a national drug code, an NDC on it, so that we can track it back to the actual medication that the patient received. Now, I said this, and I'm not trying not to gloss over it, but modifiers become very important to this billing structure because they do a couple of things. They communicate to us the administration of the medications, they drive pricing, and they also communicate the actual product itself in addition to the NDC, so where we have down here whether it's the generic or brand name. All right. Because we're dealing with a medical niche, if you will, for want of a better term, our scope of practice or practitioners here is the cohort of our medical practitioners, ranging from physicians to physician assistants to our clinical nurse specialists, certified nurse practitioner, licensed practical nurse, or a registered nurse. So kind of in our lead-in to rendering provider, we need to make sure that when these services are provided, that they are provided within scope of practice by one of our medical professionals here. These are really medically based services and medically based coding for that. So the next slide here, if you attended our 201 trainings, you've seen this slide before. But one of the things that we have managed to do to bring up this coverage without having to do a ton of rule work and a ton of legal structuring is use the existing regulatory structure. So in this case, we have an example of a methadone license. And if you haven't heard me talk about this, the methadone license is very unique because really the thing that it brings online is the methadone administration. And towards the end, I'll explain a little bit more about structure because we have to deal with one of the codes where it exists for two things here for a little while. But these entities also have a pharmacy license because they're holding and dispensing medicine. So rather than create a new structure, we have borrowed these to bring up the coverage options that I'll talk about here in a couple of minutes. Now, one of the major things here for methadone is the ability of a methadone license program under federal regulations. You see it there, 42 CFR section 8.12 H41. In our methadone program venue, it's referred to as time and treatment. So there's some permissions to give patient take-home medications. But our OTPs, our licensed methadone programs, may bill for the administration of methadone using the H0020 and the modifier HF for a daily administration. So when the patient comes in, takes their medicine, you would use HF for every day if they're coming in on a daily basis. Now you can see below the time and treatment chart allows higher levels of take-home doses depending on how long the individual's been in treatment, and they also actually have to be authorized, if you will, by the medical director. So it's not just that, but there's a whole lot of things that go into determining if or when a patient may take home. But for our purpose, we structured it to the permissions that you have. We're not dictating or expecting any clinical model under here, but just explaining how you can bill depending on the number of take-home doses that are administered to a patient. So you can see that chart. And we can go into the coding structure that actually supports this depending on the decision that is made at the OTP about whether the patient does take-home doses or not. So again, I mentioned administration of methadone using the H0020 with the HF modifier for patients that are coming in on a daily basis and ingesting there on site. Or you will bill using the H0020 with an appropriate modifier that represents the take-home doses that are administered, and that's scaled across up to 4 weeks, so we can talk about that in a little bit down here. With a modifier to represent 1, 2, 3, or 4 weeks of take-home medication, so you can actually get up to 28 days using this structure. Again, that the patient has to meet the CFR requirements. That includes medical authorization from the OTP. And of course, as is stated in the federal guidelines, and here you have to maintain documentation that supports the number of take-home doses that are administered. So we'll be able to track this back to the day the patient came in, and by the coding structure, we'll have an idea of how many take-home doses they actually took with them when they left. So there to the right, the top right, if they're seen every day in order to get their methadone, it's just the HF modifier, and you're going to bill that every day that they come in. If there is a weekly administration, so bottom left corner here, the OTP will not be able to bill or not get paid for any other face-to-face visits during that time period. So you're going to have to actually look at the billing structure and how your patients are receiving take-home medications to get a structure for providing those and for billing those using this structure. And of course, the date of service on the claim for H0020 must actually be the date that the patient was seen in the office to receive their medications. That way we know that's the date that they actually came there and visited the provider site. So anybody who came to our 201s, we talked about these. These have a little different language in them. We helped clarify a couple of things. around billing here. But we're also bringing online the 99211, the low-level medical established patient office visit code. If there happens to be an instance where you as an OTP administer naloxone, the rescue drug, on site to a patient. So there's a service code and there's a medication code, that's the J2310. Keeping in mind, again, the 2310 needs to have the NDC on it. We also brought on the injection code, the 96372, if you happen to inject the medication there on site. So we have two pathways there, depending on whether it's a nasal administration or an injection. We also have a method that if you dispense, dispense and provide a injectable nasal naloxone kit to a patient under the pharmacy through kind of the pharmacy line of business, as long as you do this in conformance with the Board of Pharmacy requirements, and you can go on their website if you're not already an OTP and pick up they have a sample, can't think of what it is, it's the permission that's by a physician to do this. You can actually provide individuals with takeaway of the reversal kit there, and you can bill us for it. It can also be provided and can be billed for the actual kit itself under revised code 4731.941. So if a patient is saying their physician there at the site and the physician provides them, that's what this one sets up and provides coverage for. We also have a structure to bill for oral naltrexone, which was requested. And this is the code that I'll talk about in a little bit later, because J8499 serves a dual purpose here for the OTPs, because they also actually operate as a general SUD treatment program. So we need you to do a little something with modifiers here so we can distinguish when it's oral naltrexone versus potentially generic buprenorphine for induction or titration. And then we have the venipuncture code per draw when the sample is sent to an outside laboratory for testing. So there are times to take a blood sample and send it out. We have now a pathway to accommodate the collection of that when it is obtained and then sent externally for testing. All right. Probably one of the things everybody has been patiently waiting for here is one of our billing guidance charts. And we're using our Medicaid provider type provider specialty speak. So a 95951 is a licensed methadone program. So as a licensed methadone program, you have methadone administration coding. That's the top box there. The service code itself is always H0020. But as you see now, there is a modifier you must use, one of those modifiers and only one of them, to indicate the medication that's been administered. So again, if they're coming on site, getting their medication every day administered, it's always HF. If they start getting permission and they have take-home doses administered, you begin to get into using the TV for weekly, which represents a band of 2 to 7 days. UB, which is a band of 8 to 14 days, so that's up to 2 weeks, something in the 2-week range. TS, when you're into 3 weeks, which is 15 to 21 days. And HG, when you're into 4 weeks, which is 22 to 28 days. We can only go up to 28 days under this structure. Sorry about that. So that's what you need to do. And again, I mentioned earlier, the modifiers are important because they drive the payment amount, and they also determine when the next claim that comes in will actually be paid based upon that number of days. So I'm sure people have gravitated and you're looking over at the rates. What you will see is just those rates are the daily administration rate scaled up to the maximum number of days in the week. And that's one of the reasons that, for example, if you happen to have a patient who you give 3 days worth of take-homes to, they would actually you would need to use the TV modifier. That patient should come back and you need to give them their medication for the other days. But because we've already paid for it, we cannot pay for it again until that week has lapsed, if you will. That's where I'm saying you need to really take a look at this payment model to match it up to your patient attendants and the amount of take-home medications which they may be leaving with on a day that they visit. So then the next ones cover our OTP, the 99211 for the nasal Narcan administration, the injection code for if you happen to inject the Narcan, and then we have our J8499 down here for the oral naltrexone per 50 milligram tablet. You will see there is a modifier HG. So in order to actually let us know that what you have provided or administered, sorry about that, is the oral naltrexone, you must put that HG modifier on the J8499. Otherwise, it will think it's the generic buprenorphine, and it will price and pay it at the 55 cents per milligram. So then we have the J2310 for the actual Narcan medication itself, and then the 36415 for the venipuncture. Now, if you take a look down there at the bottom, it's just a little extra note again. If you do the testing on site, that code won't be paid. It actually has to be collected and sent off-site for testing for the collection code itself to be covered. So now our second version of this is for our SAMHSA certified OTPs. If you came to our 201s, this is where I say our licensed methadone programs all are also SAMHSA certified OTPs, so many of them have already enrolled to bring online the ability to provide the buprenorphine medications. We also have a couple in the state that are just SAMHSA certified. So when they come online, they get pretty much everything. The only thing they do not get is the methadone because they're not a licensed program, so that's one of them. They cannot use that medication unless they do come to the state and get licensed. So, but again, you can see here, this is an example of a SAMHSA certificate. So that paired up, if you will, with the pharmacy license is what we're using to bring on the additional code sets for billing for SAMHSA certified OTPs. So the next slide is pretty much exactly the same as the methadone. We just swap out the code, the T1502. So I won't go too terribly much through that, but it's exactly the same. Although the code is different, the modifier structure is exactly the same, and it's very important, again, to have the modifiers on there so we know the interaction you're having with the patient along with what to pay and how long to lapse to the next payment. So, jump up again. So this is pretty much exactly the same as the slide I went over a couple minutes ago. If you note, the distinguishing one is there at the top, because in addition to the T code, the T1502, these OTPs will need to bill the appropriate J code. That's that J0571 through 0575, depending on the milligrams of medication or the medication that's administered on site. And then for take-home doses, these OTPs will need to bill using either the S5000 or S5001, depending on whether it's generic or brand that the patient is provided. So other than that, all these are exactly the same, so I won't read over them again. This one will look pretty similar. So up top here for the buprenorphine naloxone administration, we have daily, 1 week, 2 week, 3 week, and 4 week. The modifier array over there is exactly the same, HF, TV, UB, TS, and HG. Pricing is exactly the same. So the administration for either medication is paid exactly the same. Now, I forgot to say, in our MIT-speak, provider type specialty 95953 is the SAMHSA certified OTP. So just when you see us switching to that numbering, when you switch to that numbering, that's just our way of kind of describing a different type of subspecialty, if you will, provider. Mary just reminded me to let you know that SAMHSA, I mentioned earlier, there's 7 of these that have enrolled. For our existing OTPs, if you want us to activate this for you, you need to submit enrollment, and I'll talk about that in a later slide. If a provider happens to get SAMHSA certified after this, you still will need to let us know. That's why we put down and wrote down, here's the instructions for enrolling. It's not onerous at all. You just send us a copy of your certificate, and we do some things, but I'll talk about that with the next slide. Again, we have our 99211, established patient in the office. In the instance, you may need to administer the recovery drug there. We also allow for the injection. The medications is an expanded list just because there's more J codes for the buprenorphine-based medications. The 0571 being the mono product per milligram. And then you can see the J0572, 73, 74, and 75. Those were assigned, and they have just bands of the milligrams. Once you hit the 75, there's no code above that. So if you use a product with 12 milligrams, that's the code that you have to use. Then we have the S codes in there. And then you also will see, again, we have the J8499, again with the HG modifier. This, in this instance, represents the oral naltrexone. If you do not put the modifier, I will remind you again, it will actually pick up the pricing for a non-OTP substance use disorder program and pay at the 55 cents per milligram. So it's very important you add that modifier when it's the oral naltrexone here. And again, the venipuncture code, and again, our note down there at the bottom about we'll pay for it when it's sent externally. If you do the testing internally, this code won't be covered. All right. So we thought we'd give a couple of examples. Again, this is not any clinical advice in any way, shape, or form. It's a way of trying to explain the coding structure and how you can use it in the future to bill for services. And these are a little detailed, but we were trying to provide that because we know everybody's coding their systems, not just providers, but managed care plans. And I will mention some of the boards because I know a number of them are working as, if you will, trading partners on behalf of providers. So there's a lot of interest in understanding the coding. So these are methadone ones here in particular. So the first one is for the patient that's coming in every day and is getting their methadone administered to them every day. So for that patient, you'll submit a claim using the 80020 code. That code will always have a unit value of 1. There are NCCI edits, so we've accommodated 1 because if they ever take it to 0, that means the code is taken out of use. And the modifier is HF. So it's 80020, unit of 1, modifier HF for your daily administered patients. So you submit that for every day the person visits and is administered the medication. Again, the cost of the medication and administration is, both of those are covered under the payment for this code. And it will not be paid again until at least 1 day following the date of service. That's 1 day elapsed because they're a daily patient. Now, things get a little trickier down here when we go to weekly examples, and we only use 2, the 1 to 90 days and the 91 to 180 days. And remember, these are permissive. So unless the OTP has actually approved the patient to do the take-homes, they're probably coming in for daily administration. But in the instance where you do begin to give patients the take-home permission, so for somebody in the 1 to 90 who has approved them for, they would be approved for somewhere between 1 and 3, so it could even vary underneath there. The OTP would submit a claim using the 80020 code. The unit value, again, is 1 and will always be 1. But this time, instead of the HF, you will put the TV modifier because if you remember our chart, it said weekly is 2 to 7 doses. So anybody here, you would need to use the TV modifier. And you'd bill for the date of service. It's the date that the person actually visits the OTP and is administered their medications, including their take-homes. Again, the cost of the medication is included in the administration service payment. So on this one, just to point this out, the payment, I'm going to go looking back. Somebody, table real quick. The payment for this would actually be $114.66 because we've scaled it to the 7 days. So the person may return within that 7-day time period, but you've already got covered for the administration, so you don't need to bill it again, but you'll need to look at the timing depending on when they return for medications that are outside of that time period. So especially since the medication is included in the payment along with the administration, there's no separate J or S code that gets billed. And because this has the TV modifier, it will not be paid again until at least 7 days following the date of service on the claim. So then from 91 to 180 days, you'll see the difference here is that the permissiveness under the federal regs is they can take 2 to 4 days worth of take-home doses. Interestingly enough, this still lines up with the TV modifier. So a patient here would have their service billed using the H0020 code again, a unit of 1, and the weekly modifier, the TV, because we're between 2 and 4, which is still under the 7 days. Again, the cost of the methadone medication is included in the administration payment, and there are no additional billing of J or S codes, and because it has the weekly modifier, it will not be paid again until at least 7 days following the date of service on the claim. Now, logically, you can actually follow that pattern up through the time and treatment to get to the other modifiers. So moving on, let's do the buprenorphine-based medication examples. This one is a little different because there is no time and treatment scale. That's not the best word I want to use, but time and treatment permissions, if you will. And because we actually have pricing and payment for the medications outside of the administration code itself. So for a patient that is coming in for daily on-site administration, they're visiting the OTP every day for their medication administration, you would bill a claim using the T1502 code. It will have a unit value of 1, and we carry that practice through. There's no multiple units. It's always 1 for both of these codes. And in this instance, because it's a daily administration, you'll use the HF because they're coming in every day. So for each day they visit and administer their medication, you use that billing structure. It will not be paid again until at least 1 day following. Not bill it twice on the same day. But in this case, you actually need to submit the appropriate J code. And you need to use the J code that matches to the milligrams of the medication that was administered. And because this is a quasi-encounter code, the unit here is only 1. And the date of service is the day that they visited the OTP. Please keep in mind, we need the National Drug Code, the NDC, reported on the claim. It accomplishes a couple of things. One, it allows us to track it to the manufacturer and the product and all of that. And 2, it is used by the Department of Medicaid, the Medicaid program, and the claiming rebates for medication. So it's very important to have the NDC there. Now, because there is no time and treatment, we have a weekly example here. So for a patient who is taking somewhere between 2 and 7, has somewhere between 2 and 7 days worth of take-homes because the day that they come to the OTP is an administration day. You'll submit the T1502 code, again, a unit value of 1. It is 1 and always 1. And you will add the TV modifier, the weekly modifier that pays at the, what was it, the 114.66. Apologize, I don't have all these memorized, but I will do my best. And it will not be paid again in at least 7 days following that date of service because it's scaled to the weekly payment. You also need to submit it with the appropriate J code matching the milligrams of the medication buprenorphine that was administered that day, again a unit value of 1. But then you also need to add the S code for generic or brand, whichever product was provided. But the unit value in that actually needs to represent the actual number of milligrams of the buprenorphine-based medication that was administered for take-home use. So in this case, we actually will see 3 codes, the T1502, a J code with an NDC, and an S code with an NDC so that we can track back to the day the patient came in, the medication they were administered that day, and the medication that was administered for take-home use. Date of service on all those codes is the day that the patient came into the OTP, because it all occurred on that day. And they were administered their medications, including their take-home doses. In the Q&A, and I will stop here for a minute, somebody did ask, so if you bill for a weekly set of take-home because the patient got between 2 and 7, would you bill another day if they came in, let's just say on the 3rd day, using HF? You can bill it. It will not be paid because we've already paid you for that under the weekly payment. So, I mean, it may be a technicality, but you'll need to work with your IT vendor to see what sort of billing solution, but it's where I keep saying that if, depending on the modifier you use, MITS will not actually adjudicate another payment until that time frame has lapsed. So I'm not trying to be flip, but billing and payment are two separate things here. So hopefully that helps. Again, once we're done, we will post this up, and we'll be available. We are available to help folks as you go through the manual, including a better understanding of billing structure. So I mentioned about enrollment. So we have very specifically here a sample guidance, if you will, on how a SAMHSA certified program would enroll, and this would include our licensed methadone programs that want to add the ability to use the buprenorphine-based medications. So we've notified you of the new specialty, which is 953. Doesn't really mean a lot to you all, but it does to us when we look at provider types and specialties and MITS. So what you do is you send an email, and right there's our email address, mhas-bh support@mha.ohio.gov. That actually comes in over to Mental Health and Addiction Services, and one of the folks that works with me monitors that mailbox to help process provider enrollments and changes with service lines, if you will. Just let us know what you're doing. If you actually want to add methadone and you have both of these, you would need to let us know, and you would need to include your methadone license and your SAMHSA certificate. If you happen to be an entity that has chosen only to do the buprenorphine-based medications, you would send your SAMHSA certificate. We verify it by just looking at the SAMHSA registry. There's no real magic there, just to make sure that it matches. And then we do some things behind the scenes to communicate over to the Department of Medicaid, and then they add it into MITS to your provider record, enrollment record. Is that the right way to say it, Mary? Mm-hmm. And then it's activated, and you get not just the buprenorphine codes, but you'll get all the other codes that we mentioned, the 99211, the ability to use the J8499 for oral naltrexone, the venipuncture code, the 99211, and the sundry J codes that we've talked about. Now, we just want to make note down there at the bottom that unless you have this specialty, claims will be denied. So you have to let us know, and then we'll activate this for you when you're SAMHSA certified. More or less the same thing if you're a provider and you actually decide to get into the methadone line of business too. It's the same process we would use to turn that on for you. I apologize, between the 201s and everything, my voice has been tested this year. All right, testing of new codes. We're gonna have to talk about this kind of in two groups, so humor me here for a little bit. There is a portion of this code set that actually is coming online January 1. And for any provider, we'll let you know when that coding is available in the system. Technically, I think it goes into the testing area and the production area. But we're assuming that you as a provider want to test it yourself to evaluate claims and results before you just jump into billing straight away. So once you receive that notice, trading partners can begin testing, and then you make the decision when you move into submitting claims in the production system. So our next slide actually contains the coding that will be available in this code set. I probably should say here that although we have a little difference in when some of the codes are coming online, policy-wise, everything goes into effect January 1. So even if when we get to the next code set, policy-wise, all of this is still effective January 1, even though we have a little difference in when some of this becomes active in the system. So you can see here we have the 99211, the 96372, the sundry of J codes here for the buprenorphine medications, for the naloxone, and the venipuncture code. So all these will be coming online for January 1. ODM will make an announcement, and then you need to work with your trading partner for testing, and then when you move into production for these, if you happen to use them. Now, here's our little nuance with this. We actually have a set of coding, which is really the methadone and the buprenorphine administration. So it's really the core of the coding that's actually not going to be able to come online until January 11th. And apologize that it isn't for January 1, but it took a little bit more in terms of the MITS bill, especially when we got into modifiers and the weekly payments. So to fulfill the commitment that the directors did, we had to make the structure itself work. So that is a little bit off from January 1. But again, I said policy-wise, it all goes into effect January 1 itself. You know, not sure that any of you would be quite ready to do the billing, but that way you can at least begin to implement the practice, and we'll catch the coding up off by about 11 days here. So for the subset that we'll go over here in a minute, looks like right now we're on track for it to be in MITS January 11. And any fee-for-service claims for these prior to when we get it in there, if you submit them, they will be denied. Just quite frankly, that's just because they won't exist in the system. And then once we send the notice, again, your trading partner can start testing, and we're setting that up. We don't authorize or bless you, if you will, to do this, but it's for your own good, for your practice, and for your claiming ability to make sure that what you think is happening with your claims actually will happen with your claims. And of course, we don't expect it, but on the off chance something happens and we won't make that date, we will certainly let everybody know. Here's the code set. So what you see here is the change in the methadone administration code, because we need all of those modifiers to indicate the amount of take-home medications that were administered. The buprenorphine naloxone administration code, the T code, the actual S codes for the medications, and I want to point one out here. You will see two variations for the S5000 code. There is one for the what we call the combo product, the buprenorphine naloxone generic. There is also one for the generic mono product. Now, for anybody who's been around, you may recognize that modifier. It actually, if you go and look at all of these modifiers, they have some different meanings when you look in the modifier, and I can rattle those off. HF is tagged as substance abuse program. TV says special payment rates, holidays, and weekends. UB is Medicaid level of care 11 as defined by the state. TS is follow-up service. HG is opioid addiction treatment program. And HD is pregnant parenting women's program. We had to, and I think, Tanya, you carried the brunt of this one, trying to figure out modifiers to carry out the pricing. So we really need folks to understand that is the core use of these modifiers. So please don't gravitate or get hung up on the actual national definitions for this. So some of them make somewhat of sense, so that's why I was mentioning it here, because a pregnant woman should not be receiving the combination buprenorphine product. Likely an individual pregnant woman would receive the mono product or the methadone. You know, but we really are using these modifiers to drive pricing. And then I'm going to say this again with the oral naltrexone, the J8499. If you're administering that product, you need to put the HG modifier. Otherwise, it will price and pay as if you are a non-OTP providing generic buprenorphine at 55 cents per milligram. So these are very important because they drive pricing in this structure. And again, I rattled those up. We tried to make them as logical as we could, but there just wasn't anything that fit this payment model perfectly. So again, we have a footnote down here. We said the policy goes into effect January 1, so therefore claims submitted after January 11 for this code set that are retroactive to a date of service January 1 through 10, we'll pay you for it. We just literally couldn't quite get it in the midst because of the complexity here, especially with this modifier array. Okay. Got only a couple more slides here. So I mentioned earlier about National Drug Code. So just, for those who may not be familiar with it, federal law requires medications that are billed to Medicaid have the 11-digit NDC code. There actually is a section in the manual for this. I think, Cicely, you wrote a lot of that one. So, coding, if you understand this stuff, you can actually interpret it and read it. It's on the package of the medications. It identifies the manufacturer, product, and package size. Sometimes these codes may have a missing digit. You need to zero pad that in those cases. So we're giving some additional information there. So that's the middle section where they come with a 10-digit. When you submit the code, there's no dashes in it. Somebody asked about where do you actually put it on the claim. That should be covered by your vendor because NDCs go in exactly the same spot on a claim. That's the HIPAA standard. So please talk to your vendor there. They'll help you with that. So that's just really just a little bit more there on NDCs, especially how you code them. Again, all this is actually covered in the provider manual itself. So with that, we have covered the bulk of the presentation. I'm actually going to take a momentary break, and folks, other team members can do some of the Q&A.
Hi, this is Mary Haller with the Ohio Department of Medicaid, and we've been looking at some of the questions that have been coming in, and I wanted to take the opportunity to make sort of a summary statement about how we are changing the billing constructs here for opioid treatment programs. You all have been used to billing take-homes on the day that they're intended to be taken. And from a Medicaid and a healthcare claims perspective, that's really an incorrect way to bill for those services. And so we're trying to correct that error in the way that we're changing our instruction here. That's why we're moving to this weekly billing construct. So if you think about it in terms of from a Medicaid and a federal oversight perspective, we pay for activities that occur when the provider is in direct contact with the patient. We don't pay for activities where there isn't contact between the provider and the patient. So in other words, when you have been billing us in the past, and I understand that this is the instruction that we've given, but as are many things with BH Redesign, we're trying to go back and sort of, undo some of our own Ohio homegrown rules here and move to a national coding standard. We want you to bill according to the day that you have seen the patient. So what you are doing is you are billing us for what occurred on the day of that visit. And so if you think of yourselves in terms, with regard to take-home doses, if you try and frame your understanding of what we're talking about here today in that way, I think it will help you to understand this new concept. We really are changing the frame from the way you have been billing us in the past. So think about your billing according to what occurred that day. So if the patient comes in, and I'm going to try and read here one of the examples. There was a question about, oh yes, the patient comes in, gets a dose of methadone in the office and gets 10 take-home doses. The day that your face-to-face activity with that patient occurred is the day on which you will bill all of the activity that occurred in regard to that patient. So that includes both the take-home dose and the dose that was administered in the office and the 10 take-home doses. And with regard to methadone, you're going to be billing only the administration cost. You're not going to be billing the drug cost because the drug cost for methadone is very low. It's pennies. It's a little bit different with buprenorphine. I don't see the 2-week. Oh, so you would modifier. Yes, you would use the 2-week modifier because it's more than 7 days.
Between 8 and 14, that
right.
2-week modifier is UB, and then it would not actually pay, MITS will not pay a claim again until after 14 days.
Yeah.
So you all are actually, and appreciate the ad-lib, ad-lib's not a good word.
Ad-lib, that's exactly what it was.
But you all are actually picking up. You need to start looking at this framework, this coding framework, this payment framework, and how it fits in. So there is no, somebody asked, so if we do 10 days, can we continue to bill 80020 and HF on every day? The answer is no. So we're providing the webinar today so you can start getting acclimated to this and going back and working on understanding it and how this will fit in the new world.
So again, there's a question that came in about Vivitrol. So Vivitrol's a little bit different because it is it's a one shot for 30 days medication. When there are recalls that occur, I guess what we're thinking is that if your activity with that patient is related to the administration of the medication, then there should be no additional claim because your agency will have already been paid for the administration of the medication. However, if during a recall a different physical issue, a different healthcare issue arises that requires a physician intervention, that requires a urine drug screen, that requires some other kind of intervention, then that is not part of the administration payment that was made to your agency. And so there would be no problem with that being billed on the date that the recall occurs. However, we would want your medical documentation to note that there was a different problem that arose during that recall visit. Okay. What if the patient is given only one take-home in a 7-day period?
Okay, yeah, I'll take this one. When I explain that HF is daily, so that's the patient coming in and they're getting their medication every day. So when we say weekly and we say two includes the one they get the day they visit and the one they left with. So the answer to your question is you would use the weekly code because they were administered one that day and they were administered one to take with them. They were administered a total of 2.
And the patient can come in and continue to get in person for the rest of the week. You would just not, we would not pay for another bill until after the 7 days has passed.
Right.
Well, we do keep getting this question, can I continue to bill 80020 HF?
No. No, Beth.
This is where I'm kind of backing up for a minute. We have recorded this, we are posting this, and we appreciate that folks are starting to think and have a lot of questions. We cannot go a one by one through all of these. We have all the questions recorded, so we will take that to help inform some of our additional communications, if you will, on this. It sounds like some folks are hanging up. We're actually going back through the questions, so I apologize. We're trying to pick up a couple more. We found some thematic areas, like where to put something on a claim. I'm not trying to cut this one off, but we've said a number of times that and Mary reinforced it, there is no longer just a repetitious daily billing of these codes. You have to start matching it to the amount of medications that the patient took with them, because that matches the date of service physically where they came to the agency. So if I apologize, I should have told you before, we're scrolling through the questions to try and find a few of them so we can answer a couple more. Hold on a minute.
So one of the questions was, where does the NDC go on the 837P? And it goes into the segment LIN in the loop 2410. Another question was modifier. Someone thinks modifier means modifier 3 position. Modifier to us, it could go in any position. You just need to fill it from 1 to 4, depending on how many modifiers you're putting in there. It just needs to be in one of those fields.
So in other words, in MITS, it doesn't matter what order the modifiers come in on a claim, as long as they're there in one of the first 4 positions. Is that right, Tanya?
Yep.
MITS interrogates it for the existence of the modifier.
Correct.
And that there's not another conflicting one where we said you can't put 2 of these.
Right.
But where the position in there, it really doesn't matter. It just interrogates for its existence. Oh, I also want to say, folks who are asking about the Vivitrol, that is actually not covered under the OTP benefit. It's covered under the general SUD treatment program benefit.
Right.
That's why we haven't been talking about it today. We're talking just about the OTP changes.
And that won't change until July 1st of 2017, when all the rest of the changes go into effect for the behavioral health redesign. We have set up the implementation of some of these codes for opioid treatment programs, specifically because those programs requested the addition of these codes, the addition of some of these practices to help them in their treatment of individuals with opioid addiction. So, and given the fact that Ohio is experiencing a lot of problems with opioid addiction and heroin overdose, we at the administration wanted to put those changes in effect as soon as possible. And so that's why we are expediting the implementation of these changes for opioid treatment programs.
Okay, there was another question pertaining to this is an existing methadone clinic that's closed on Sundays, and that's the only day that they give take-home medications for. How would you bill that? Well, depending on the day the client comes in, so if that's the only one you give it for, I'm assuming they're coming in on Saturday. So every Saturday, you're going to be billing H0020 with the TV, which is a week. So when they come back in on Monday, you'll go ahead and give them their medication. Then they come in on Tuesday, you'll give them their medication. When they come in on Wednesday, you'll administer their medication. When they come in on Thursday, you'll administer their medication. When they come in on Friday, you'll administer their medication. When they come in on Saturday, you'll administer their medication, you'll give them their take-home, and you'll bill again using the TV modifier.
So we're responding to a question about venipuncture. Tanya?
Yeah, there was a question if an agency bills the venipuncture, if the outside lab can bill for the testing, and yes, they can.
There was also a question about oral buprenorphine, and can more than 1 milligram be dispensed? Yes. I believe that our rate of $1.20 is for a 50 milligram tablet, if I remember correctly. Oh, it's naloxone. I apologize. I'm wrong. Cicely, correct me.
If you're doing take-homes of multiple milligrams, you'll use the S codes. If you're doing in-office administration of multiple milligrams of buprenorphine, you'll use the J codes. The 1 milligram is for provider type 995, 950, and it's just for the induction and titration.
Okay, so we have a question. For H0020, the modifier is HF. If it's a weekly take-home, do I remove the HF and replace with TV, or does the HF in modifier 1 and TV in modifier 2 position? What Tanya just explained, and so did I, is that MITS doesn't care where the modifier is, but they are mutually exclusive. Do not submit HF and TV on the same claim. It will get denied. For a weekly patient, you would submit the TV 2 to 7 days. For a patient who's coming in every day, you will use the HF.
So in the OTP draft that was submitted earlier, the manual, 96372 had a different fee for depending on who the provider was. So because we don't know who the rendering provider is until July, we cannot make the rate different based on who is providing the service. So we've just had to stick with the current rate that is in production today, which is $14.57. Come July 1, when all the other changes go into effect, the rate will change.
Just as a quick reminder, if you go to bh.medicaid.ohio.gov in the manual section, we have posted the OTP manual a few hours ago, I believe. We will also be making available the slide deck here. We will, depending on what we do with the questions and answers here, I'm assuming we will post them there too, to the extent we need to. So we do appreciate everybody attending today. We hope that it was educational. We did cover a lot of territory.
Are we going to try and answer the last couple of questions?
Okay, we got one more.
So the question that talks about if you bill the J codes for if you're doing it in office, and then the S codes if you are sending home take-home, that is correct. The J codes are for in-office administration. The S codes are for take-home. So depending on how you do a week of take-home in-office, will determine which days you are billing for the S codes and which days you're billing for J codes. So that is correct. And then, yes, if you bill a weekly modifier for buprenorphine or for methadone, we will not pay again until that week is over for another dose.
Thank you again, everybody. We appreciate you joining us. Again, we shared a lot of information. Go back, digest it. Again, we'll get everything posted. We'll figure out a place where we actually post the recording itself, and actually have a good evening and a good weekend, everyone. Thank you.